Hi, everybody. We're really excited to welcome Dr. Kristin Fujita today, one of our Peds cardiologists. She's been here for a couple of years, actually, I think already, right?
No,
Um,
I'm coming up on year one next
is
month.
it year one? Okay, so she's been here for a year with us, helping us out with our many, many complicated cardiac kids. So I'm really glad to have her here talking about a cardiologist perspective on Kawasaki disease.
I'm going to be talking about Kawasaki disease from a purely cardiologist perspective, as we see a lot of these patients at Kapilani, actually. I have no financial interests or conflicts of interest to disclose. And then we went over the learning objectives already, so I'm just going to jump right into it. So this is an example of a case that I saw in fellowship, actually, of a 3-month-old exotherm twin. She came with 4 days of fever and congestion, so something that uh, you guys see all the time. No respiratory distress, no cough, rash, GI symptoms, drinking well, and peeing normally. No past medical or surgical history, and no significant family history. So on her first presentation to ED, she looked really well. They did some general labs, given that she was a baby. And they sent like a urine culture and a COVID swab. At this time, COVID was more prevalent. Um, and she was discharged home. She was called back to the emergency room after the urine culture resulted in Pseudomonas. It ended up being only 3,000 colonies, so they eventually thought it to be a contaminant. Um, and so around this was actually the same presentation. She happened to still have fever to 102.4. Again, she was very well appearing, had non-focal exam. They sent more labs, and this time she had an elevated white count, CRP, D-dimer, and fibrinogen. Her LFTs were normal and albumin were normal. And her X-ray looked like this. It was kind of red. It was red as like streaky perihilar interstitial opacities. Um, so I'm going back and forth. And then they swabbed her again, which showed that her respiratory viral panel was negative, um, and COVID antibody was negative. That was back again when COVID was more prevalent and the whole MIS-C was coming about. So she was admitted to the floor, the regular pediatric floor, essentially given the persistent fever and just to kind of see how things evolve. She was on the floor for over 24 hours, um, not getting antibiotics, and she was actually afebrile, therapeutic admission, and she was discharged home. And then, of course, later that day, she had another fever after she went home. So they said, come back to ED again. They didn't come back that day. They came back the following day um, with possible red eyes. They did labs again. Platelets were elevated, white count was elevated, and so were her inflammatory markers. And again, her liver LFTs were normal. UA was negative for white blood cells. And then they also sent some like cardiac uh, markers, and her troponin BNP were normal. Although I'll put in a plug in terms of BNP, if that was honestly a little bit high, I wouldn't put a whole lot of stock in it. It's a fairly non-specific marker. So I get a lot of calls about like somewhat abnormal BNPs. Um, and, I usually say the same thing. It's fairly non-specific, unless it's like ridiculously high in like the 10,000s region. Um, I would just repeat it when the patient is their symptoms are getting better or whatever the cause is kind of ironed out. And this was her EKG, very normal EKG for someone her age, normal sinus rhythm, the ST and T waves of normal. And so the differential diagnosis at this point in time, viral infection, bacterial infection, Kawasaki disease, and at that time, MIS-C as well. And so I'm sure a lot of you guys know this figure very, very well. evaluation of suspected incomplete Kawasaki disease. So she was not the typical classic presentation. Um, and as you guys know, there are different clinical criteria to meet. And if you're an infant with fever greater than or equal to 7 days without other explanation, you should look at labs, and these lab values can help you determine if they have incomplete Kawasaki. So for her, she had the elevated inflammatory marker, so she's in this box. Um, Anemia for age, hers was actually normal. Platelets were elevated. Albumin was normal. ALT was normal. Her uh, white blood cell count was high, and her urine had no white blood cells. So she got an echocardiogram to essentially see if she has any coronary artery involvement that would be suggestive of Kawasaki disease. And I'll show you that in a second, but before I show you that, this is normal coronary artery anatomy. There's the right coronary artery and the left main coronary artery, which generally branches off into the LAD, the left anterior descending artery, and then the left circumflex artery. And so on echocardiogram, this is like a typical, this is like normal echo of proximal coronary arteries. So again, echo, we are in kids, we're able to generally see the proximal coronary arteries, but sometimes it's very difficult to see. And like technically speaking, it's just if their windows are poor, if they have really bad lung disease, I'm like thinking more about like the small premature infants, it's very, very difficult to see these things. So, and also coronary, on echo, we essentially can only see the proximal part. So there's a whole bunch of coronary artery happening over here off the screen that we can't evaluate on echo. And the only way to see that is either like CT imaging or uh, going to the cath lab and shooting coronary angiography. So this is like what a normal appearance of the left main coronary artery looks like, circumflex and LAD. And then on this side, this is a normal proximal RCA. And there are Z-score norms as to the actual like size measurement for age. And so this was uh, the patient that I just talked about on the left-hand side. So this was her right coronary artery. And as you can see, it compared to this normal here, it looks bigger. Um, Bigger, there's like this more dilated aneurysmal area, and it just does not look normal. And so when we measure it, the Z-score is 8.3, so severely dilated proximal right coronary. And then this was her left coronary artery. Again, this is the normal, kind of uniform, fairly um, uniform, slim looking, no big dilations or areas of stenosis. This just looks honestly really ugly. It doesn't even look like a coronary artery. So the left main measured with a Z-score of plus 4.7, and the LAD was like severely dilated. The Z-score was almost 17. And so there's the AJ essentially guidelines out there talking about Kawasaki disease and specifically like the cardiac management of it. And there is different Z-score classifications to essentially describe how dilated or aneurysmal coronary arteries can be. So Z-score under 2 is normal. 2 to 2.5 is what we call like dilated. Small aneurysm is like 2.5 to 5, then 5 to 10 is medium, and above 10 of a Z-score is large or giant aneurysm. So for this patient, her right coronary was in the medium range, left main was in the small aneurysm range, and then the LAD was in the giant range. And this becomes important, these classifications become important in terms of like long-term management of these kids. And so for her, with the lab work and also, and actually no, just with the positive echocardiogram, she automatically meets criteria for incomplete Kawasaki disease. Um, and if you read the subtext, basically there's criteria for what's considered a positive echo. But of course hers is wildly positive. And another thing to mention is that there are other things other than coronary artery aneurysms that we can see with Kawasaki disease. So you can have decreased function, you can have valve involvement with acute like regurgitation, you can have inflammation with shown with an effusion or signs of like myocarditis. So there's other things that we look at when you guys order an echo for like a rule-out Kawasaki patient. And so she was she was admitted to the ICU. Oh no, transferred, I think. Oh, she ended up in the ICU, given the severity of her coronary artery involvement and for telemetry. She got IVIG. She also got steroids, which is not, the norm, which I'll kind of briefly get into, but short to say, rheumatology was involved. And then she was started on therapeutic anticoagulation and aspirin. So this is stuff that, I'm sure you guys all know. So Kawasaki disease is not usually, it is an acute self-limited febrile illness, seen commonly in kids under 5. And young infants are more likely to have incomplete and or severe disease. So just like the patient that I described. It's a small medium vessel vasculitis. Um, no known trigger, but thought to be some sort of infection or something. And uh, we we try to catch Kawasaki disease within the first 10 days to prevent coronary artery aneurysms and complications from that. So the widely shared like statistic is like the timely treatment reduces the incidence of aneurysms from 25% to around 4%. And the physical exam findings you guys are all familiar with in terms of like rash, conjunctival injection, dry cracked lips or tongue involvement, hand like extremity swelling, peeling, involvement of some sort, and then lymphadenopathy. I think that's what this is trying to show us. So in the acute febrile phase, there's multiple organs that can be involved in Kawasaki disease. So in the liver can be involved with essentially hepatitis. Lungs can be inflamed. You can have GI symptoms. You can have aseptic meningitis, irritability, which is classic for Kawasaki disease patients. The sterile pyuria, pancreatitis, and lymphadenitis. And of course, what I care about the most is the heart involvement can, as I mentioned before, vary from myocarditis, pericarditis, um, valvulitis, and coronary artery aneurysms. So you can have inflammation of essentially anywhere of the heart. Um, you can see valve dysfunction in about a quarter of the patients. So it's a little bit more common than what people usually think, but this could just mean any degree of like regurgitation or something. You can also have involvement of the essentially electrical activity of the heart, so the sinus node or AV node. You might see signs of like PR prolongation, first degree heart block. However, in isolation, first degree heart block is not necessarily abnormal. That's a normal variant. So everything just has to be taken in context and looking at the big picture. And EKG can also look for ST wave abnormalities. And then patients can also present with myocarditis-like picture and cardiogenic shock. And then another just comment is that, there's a higher risk of what's called like IVIG resistance or treatment failure if you present, in shock or what I would consider to be more severe Kawasaki disease. So in terms of cardiac findings with the coronary arteries, um, you can have anywhere from the mild dilation to huge aneurysmal dilation of the coronaries. Typically, the proximal areas are more involved early on, and it can eventually lead to things can progress to distal involvement. And again, we can't see any of this distal involvement on echo, but we can see proximal involvement with that. You can also have other medium-sized artery involvement throughout the body. So sometimes, you can consider doing like a CTA or like MRA to evaluate other blood vessels if there's concern that there's other areas involved. So specifically, coronary artery aneurysms, are dangerous, and this is like a angiogram of the left coronary artery. So this is the circumflex and the LAD, and you can see that there's this huge aneurysm here. It can lead to serious morbidity and mortality. You can form clots in here. It can eventually form stenosis and essentially an MI type picture, which we rarely ever see in pediatrics. Like I mentioned before IVIG, about 20-25% of patients developed coronary aneurysms. And treating within the first 10 days reduces that risk. And while my patient had evidence of a giant aneurysm or aneurysmal dilation, it is pretty rare. And infants under 6 months of age are, they're going to present more atypically than the toddler age kids. I'm not going to get too much involved, like in detail with this, but basically, the vasculopathy with Kawasaki disease involves muscular arteries through necrotizing arteritis, subacute or chronic vasculitis, and then eventually myofibroblastic proliferation. And I'll show you a picture of what that kind of means. Actually, I'll show you now. This is actually from the AJ 2017 guidelines, actually. So it's a nice picture. Arteries have the intima, media, and adventitia, so those three layers. And here, one option is no coronary artery involvement. That's great, and actually the most common that we see. And then the next step up would be mild transient dilation. And oftentimes we see this dilation in the acute phase, and then when they come for follow-up, it kind of essentially self-resolves. It resolves. They're generally treated with IVIG and hospitalized, but it gets better spontaneously. And then on the more severe range, you can have necrotizing arteritis, where essentially multiple layers of the artery are damaged and lead to aneurysm formation. And then essentially like these, the blood vessel kind of, I think of it as like scarring forms. You get non-occlusive thrombi that forms along the dilated wall, of the artery. And you can actually, it can actually look like the arteries are now measuring in the normal range. Because on echo, all you are going to see is just the lumen. You don't know what all this stuff is going on here. So even on if echo shows that there is, things have gone back to normal, it is very possible and likely that the actual artery wall itself is still abnormal, and that there's like not occlusive thrombi there. And then long term, you can have calcifications of the walls of the coronaries. What else? I mentioned all that. Okay. So back to our patients. So given my patient's age, rheumatology was consulted, and since she was at considered to be high risk for persistent or recurrent disease, she was automatic, like upfront treated with IVIG aspirin, which is the usual. They also gave her IV steroids as well. The rest of her course, she remained afebrile. She got many echocardiograms during her stay, which essentially showed stability of her aneurysms, but they were still very much abnormal. There was no signs of coronary artery thrombosis, and so she was discharged with cardiology and rheumatology follow-up. And so 8 weeks post-discharge, she had more echoes in between this, but just to compare things. So this was her initial echo of her right coronary artery, and that was her 2 months later. So it looks like the lumen is more normal sized. Same with the left coronary artery. So this was the initial, very, very dilated. The LAD is actually still dilated, but the walls look a little bit more regular and uniform. There's no thrombosis. So things appeared on echo to essentially be more normal size. And so the AHA guidelines has a lot of detail in terms of risk classification of these coronary abnormalities. And this is where those Z-scores come in terms of if they're just dilated only, small, medium, or large. And so my patient, one of her right corner, no, her LAD was in the giant range. So she's essentially in this category here. And then over time, what we do is we kind of see where they are, how they've decreased or stayed persistent. And this kind of informs how we treat them with like anticoagulation or antiplatelets and stuff like that. There's additional clinical features that can, lead to higher risk of MI. And so for this patient, as I showed you on the echoes, her coronaries kind of regressed more to a normal size. That last echo still had a mild, small aneurysmal dilation of the LAD and the right coronary. She was on Lovenox and aspirin until her coronaries went to this small aneurysm category, and so she was taken off of the Lovenox and just continued on aspirin. There's a nice graphic representation of how her coronaries kind of regressed in size over time. And usually, this kind of change is seen in the first 6 to 8 weeks, which is why we often follow up these patients until then, at the very least. There are a lot of I guess, treatment evaluation types of flow diagrams for Kawasaki disease. They all say this kind of similar thing that I was talking about, the same clinical criteria, first-line treatments, IVIG and aspirin. You got to think if the patient has high-risk features. And based off of that, you can, and this is like high-risk criteria that they kind of added on a more recent iteration of those guidelines. So being under 6 months of age, or having a dilated LAD or a right coronary on their first echo makes patients higher risk. Kind of talked about this. So acute management is medium to high dose aspirin until afebrile. I find that the dose that is used is kind of institution dependent. There's actually, no evidence that moderate dose or high dose is better or worse. So I've seen it done both ways of what the initial dosage is. And then patients also get IVIG. And then if the patient has rapidly expanding dilation of their coronaries or giant aneurysms, to consider anticoagulation to just reduce the risk of acute thrombosis and essentially MI. Adjunct therapies would be steroids, more biologics. So all of this is if you have an unusual or very young patient or a treatment refractory patient, these medications can be considered. And so in terms of outpatient follow-up, for patients with uncomplicated Kawasaki disease, patients should get an echo 1 to 2 weeks after their treatment, and then 4 to 6 weeks later. So kind of what I mentioned before, the 4 to 6 week, or I would say for like 4 to 8 weeks after treatment is kind of when we will see changes in the coronary arteries. So you can still develop aneurysms at this time. But if at this visit their coronaries are still not involved, we could discharge them from follow-up from a cardiology perspective. Not necessarily like infectious disease or rheumatologic standpoint, but if their coronaries aren't involved by around this time, it's unlikely that they'll get involved later on. If the patient has coronary involvement, the highest risk of an MI is within the first 2 to 3 months. And patients should get at least weekly echoes in the first 6 weeks of their acute illness, especially if the aneurysms are expanding, and then space them out thereafter. And the biggest thing, the reason why that we do these echoes so frequently is honestly to make sure that we're titrating their thromboprophylaxis or like anticoagulation appropriately. Because if you don't, that can lead to increased morbidity or mortality from like an MI. So essentially just trying to manage what kinds of medications they should be on based off the size of their coronaries is very important. And so there are recommendations as to how much thromboprophylaxis a patient requires. And basically this just shows that based off if you have a small, medium, or large size aneurysms, and based off the Z-scores, there's different amounts of thromboprophylaxis you should do. So in terms of small aneurysm, the bare minimum is low-dose aspirin. And then next step up would be doing dual antiplatelet therapy with aspirin and Plavix. And then in the giant aneurysm stage, doing anticoagulation as well with something like Lovenox or Coumadin. And then adding things like beta blockers to slow the heart rate down, things that, are very, very common in adult world because MIs are obviously more common there, but that's kind of like where patients will fall if they have a severe coronary artery disease. This is from the AHA guidelines, basically looking at based off of where they are on this risk level, what kind of medications you want to consider. And so you can have anywhere from low-dose aspirin to needing dual antiplatelets and anticoagulation, and then plus minus beta blockers and statins. And as you can see, like in pediatrics, nowhere like says you should it's definitely indicated to give them beta blocker or statin. The most you'll get is maybe considered. And sorry, this changed recently in like a recent update to these guidelines, but again, there's like tables out there to kind of help guide our management. And then there's also risk stratification in terms of further testing and like activity restrictions. So basically, I zoomed in on this, but basically, I kind of mentioned before that patients who have no involvement of their coronaries, they could be discharged from cardiology follow-up after like the 4-week to 12-month mark. But obviously the patients who have involvement, they'll need to be seen or more than that. Assessment for inducible myocardial ischemia. So this is like exercise stress testing, stress echo, doing like a PET scan. That's something that we think about doing every so often, especially in the kids with history of aneurysms. And again, this is kind of it's also age dependent as well as to what kind of test they can even do behaviorally. And then another thing that's considered is like physical activity counseling. Um, restricting contact sports is more so recommended when you still have aneurysmal dilation of your coronaries. And this also um, kind of integrates how much thromboprophylaxis they're on. So like if they're on Lovenox or Coumadin, in which case they wouldn't be doing contact sports anyway. That's just in the more severe range. All right, so sometimes like I mentioned before, sometimes patients have a very severe presentation of Kawasaki disease. So essentially, a very ill-appearing patient who comes to the emergency room. Um, they can present essentially like similar to an adult with a STEMI or a non-ST elevation, acute coronary syndrome. That's what this means. Um, and they're essentially, if you suspect that they're having like acute coronary thrombosis, similar to adults, going to the cath lab is important to do in a timely fashion. It is very, very rare. I have never actually seen a patient who needs acute coronary intervention thus far. I'm not sure if I'll see it, hopefully not. But uh, just to put out there, in pediatrics, so I'm like trained in interventional cardiology, and that's doing coronary interventions on kids is very, very rare. So much so that like I have very minimal training in that. And I was trained at like a very high volume center. So it's pretty rare. So um, at Kapiolani, we do have a cath lab and we have cath team on call. But depending on the age and the size of the patient, the feasibility of getting a patient to cath lab in under 90 minutes is it's aspirational, I would say. And so another thing that could be considered is doing starting systemic thrombolysis, so TPA. There's a whole protocol for that. Um, and then, considering doing cath or CABG if necessary. Um, and in terms of long-term outcomes of patients who have coronary artery aneurysms after Kawasaki disease, um, patients over 10 year over 10 years follow-up, patients who have giant aneurysms, they have a fairly high risk of having long-term problems with their coronaries. So having luminal narrowing of their coronaries, thrombosis is like 18%, which to me is very high, and having major cardiovascular complications is about 14%. And this study also looked at normalization of coronary arteries after having aneurysms. And essentially, the smaller the aneurysm is, the more likely it is going to resolve. Not the size is going to resolve. The artery itself is still probably going to be abnormal, but lumen, like the size of the lumen, becomes normal in almost all small aneurysm patients, but only maybe like half of large aneurysm patients. This other study looked at a whole bunch of patients in Japan, and also looking at long-term coronary events. And again, based on the size of the original aneurysm, the 10-year event-free survival gets pretty low in the males in this study. About like half of them survive 10 years. Sorry, event-free survival. And so this is just a Kaplan-Meier curve describing that. But essentially, a lot of patients have long-term problems if they have coronary involvement, and much worse if they have large aneurysms at diagnosis. And so long-term management of patients with large aneurysms, advanced imaging is generally done to take a look at the distal coronary arteries, either with cross-sectional imaging or doing a cath. Anticoagulation is also considered in addition to dual antiplatelet therapy, and then the statins and beta blockers, and then long-term doing inducible testing to see if there's myocardial ischemia, and then physical activity, allowing patients to do sports or exercise or whatnot is kind of guided by the inducible ischemia testing. And so, I do have a patient that I see here that has, coronary artery involvement, and I'm still actively, assessing what to do with him. So he's a 7-year-old nonverbal autistic kid who had incomplete Kawasaki at age 2. And he was treated late, like on day 14, after essentially the echo showed major abnormalities. So he was treated with all these things, IVIG, biologics, aspirin, and he had giant aneurysms of the right coronary in the LAD and medium involvement of the left main. His function has always been preserved, and I say probably asymptomatic because he's nonverbal and autistic. So, he's running around doing his thing, but he can't tell people when if he feels symptoms or anything. And so he has been followed with yearly echoes, and currently his left main size regressed to normal LAD, and the right coronary has regressed to medium. He was previously on Lovenox and aspirin for many years, and the Lovenox actually kind of grew out of it. So by the time he saw me, he was on like a minuscule dose for his size. Based off of where he fell on that chart, I switched him off the Lovenox to just dual antiplatelet therapy. So he's currently on Plavix and aspirin, and he's been getting yearly sedated echoes and EKGs. I recommended I only saw him maybe earlier this year, and I had recommended doing a coronary artery, like a coronary angiogram in the cath lab, just because he's always has to be sedated to get an echo and EKG anyway. And I was curious as to what the distal coronaries look like. And these are some still images of his coronaries. So this is the left coronary artery, left main. It looks okay. And this is a circumflex artery and its branches, which also looked pretty good, honestly, distally. And there's just some irregularity here in the proximal LAD. So this, his left artery is not too bad. His right artery, however, it's really concerning. So this is the proximal right coronary artery, and there is just really, really severe stenosis of this proximal. I measured it under 1 millimeter. And he has another area of narrowing here. But this is really severe coronary artery disease. So, I only cathed him like maybe last month. And I actually put a Holter monitor on him, which only lasted like 12 hours before he ripped it off, which showed some evidence that he had a run of like 5 beats of ventricular tachycardia, which I'm not sure if he feels, but that's obvious. That's like a very bad sign to me that he's probably having more runs of ventricular tachycardia without us knowing. So, I'm in the process of discussing with cardiologists at Boston Children's as to what to do next. So doing a CTA, doing inducible testing of some sort, which, would have to be probably a pharmacologic stress echo or stress MRI, since he can't exercise or reliably go on a treadmill. And then like what to do next? Like, do we stent the right coronary? Do we send him to surgery? Do I add anticoagulation or a statin or beta blocker? So all these things are things that I'm considering doing for this patient, especially given that is very hard to assess if he's having any symptoms or issues at all. So yes. that is basically all I have here. If anyone has any questions.